We have joining us Dr. Andy Gardner. He is from the University of Oklahoma and head of an exercise physiology lab there, the core. And we have our own in-house Pennington expert, Dr. Catrine Tudor-Locke, who runs the walking, is it walking laboratory? Or
walking behavior.
Walking behavior laboratory, one of the world's experts in walking as an intervention for a variety of disorders. And so, again, we encourage you to go. Any questions that you have regarding frailty, falls, dementia, we ask you to please go back and fill out some cards so that we're able to continue on with your questions. We have a few in-house already. Before we begin with that, I did want to point out we will be looking in our study at understanding how changes in physical activity, both in the laboratory setting as well as home, relate to the development of dementia and increased fall risk. And so we'll be laying the groundwork with your help on what are the earliest changes, and then when we know those changes in people, we're going to be able to intervene. We'll identify those people that are at most need of having an intervention. And so it's a very important part of what we're moving forward on here at the Pennington with the IDRP study. So after the presentation, we're having questions like this, Dr. Allman. I'm still not sure about the definition of frailty. So maybe we can give another stab with our panel on defining frailty.
No, you go right ahead.
Well, it's not surprising that you all are confused about frailty because the scientific community is confused about frailty in the same way the terms dementia and Alzheimer's disease is confusing to the lay audience. Frailty is very confused as well because there hasn't been a standardized definition for frailty. And in fact, there are kind of two major camps in trying to define this. One major camp right now is using the criteria that I've described, the weight loss, the slowness, the fatigue, etc., low physical activity, slowness, and using that to define the frailty syndrome. There are others who think that frailty should encompass not only those physical measures, but emotional measures, cognitive measures, functional measures, etc. And I know that Dr. Keller and the team here are really interested in trying to advance the science so we have a better understanding of the vulnerability that older adults get. What is frailty? And they're going to be doing some research to try to link how frailty and dementia all go together.
Well, I don't know from a clinical definition, but you know it when you see it, right?
Andy?
And I agree with the previous comments. It's very hard to define, and it's kind of elusive on the definition. But I think everybody would agree that it is kind of a, it's not a either or it's not a yes you are or no you're not. There's a little bit of a continuum to that. And so, you know, when you take into the physical components to it, it's not that all of a sudden you can't do it. There's a gradual process to this. So that makes it even a little bit more difficult to define.
And I think that's one of the problems with scientists. You know, we see a continuum like that, and we try our best to draw a line where we think this definitively starts the diagnosis of it. But that's pretty much smoke and mirrors at that point.
You know, maybe a good thing to do too would be to have the panelists talk about interventions, what you've seen in your own work about exercise in different groups and its effects on improving with a variety of health outcomes in the elderly.
Well, actually, I'll say walking, of course, but Well, with walking, and actually this builds on what Richard is talking about when he's speaking about the life space sort of indicator of how well you're living. You first start in your house, then across the street and out in the community and so on. Well, to me, that actually is an indicator of walking, because we could put a gadget on somebody and get their life space and get a pedometer or accelerometer, and we would see those people who go out, you know, to TJ Maxx and then out to Walmart and then across town and maybe up to Monroe or whatever, they're going to get more values on that on a regular basis. So it is an indicator of walking behavior. And the idea of keeping mobile and keeping walking is one of those things that we would say prevent the onset or progression of frailty.
I think a simple definition of frailty, regardless of all these clinical things that we're talking about and how to specifically define it scientifically, is that frailty is a condition that puts an older adult at risk for a bad outcome if they have an insult, a sudden new condition, a new problem. So if they get pneumonia, or if they have a fall, or if they get in an accident, or if they take a new medicine, because of the combination of factors that are going on with aging throughout the body and maybe their underlying disease conditions, there's something about them that make them at higher risk for bad outcomes. So that's really what frailty is, and then that's the reason why there's a controversy about how to actually define it. One of the areas that we're particularly interested in at UAB, and I know, again, the workers here at Pennington are also very interested, is that hospitalization is a very vulnerable time for older adults. And what we have found is that if people go into the hospital for a surgical procedure to reverse some sort of problem like a hip arthritis or needing bypass surgery, something like that, they'll go in the hospital and come out, and they'll have dropped their life space score 20 points, which is a big drop. But within 6 months to a year, it's back to normal or maybe better than what they were beforehand. But we found in our community-based study that individuals that go in the hospital for pneumonia or heart attack or a stroke or routine medical problems, their life space score doesn't drop as much, maybe about 10 points. But even after 2 years of follow-up, they never recover. And you think, I thought medical doctors are supposed to get you better when you're in the hospital. And one of our hypotheses is one of the reasons why there's that drop and people don't recover is we put you to bed in the hospital and you never get out. And what we've found, my colleagues and I at UAB, is that people spend 85% of their time in bed for their hospital stay, even if they're able to walk. And that's because you're in hospital gowns, you've got IV poles and catheters, you know the nurses don't want you to get up, the doctors don't want you to get up, and the TV's right there over your TV and it's very of your bed, and there's only one chair, and your guest has to sit there. So there's real no motivation to get up. We know for every day you spend in bed, you're losing 1% of your strength. And older people are already at risk. And so if you got a frail older adult, they go to bed, never get out of bed, they're likely to have declines in function after discharge. We just finished a study at UAB where we did a simple walking test, walking intervention. And the people who did not get the walking intervention dropped 10 points, just like we predicted. The people who didn't dropped 1 point. So we think that this is very provocative, and we want to follow up on this, and we think we can improve the outcomes for hospitalization even among frail older adults.
Okay. Andy, did you want to make a comment about your work?
Yeah, just a follow-up on that. I think a lot of people really overestimate how much walking and exercise they really have to do in order to realize some benefits. And it kind of goes to this, deconditioning, if you're right out of hospitalization. I deal with exercise rehabilitation of older patients with vascular disease in their legs. And it's the remarkable thing is how little walking people really have to do or to start to realize big benefits in walking. and other health outcome measures. So, we're only talking, 15 minutes a day, 3 days a week, 45 minutes in a week that people do, and we see major increases in improvements in function. And it kind of goes back to after hospitalization, it really doesn't take a lot to rehabilitate someone back up to where they were.
Okay.
Just one more follow-up on that. We have put some gadgets on people in hospitals to find out how many steps they take in hospital, and it's less than 500 steps a day. Less than 500, that's going to the bathroom a couple times. That's about it. So if you add about 15 minutes one more day, you'd be up around 2,000 steps. So it'd be quite a big increase over your hospital stay.
What type of exercise is best for slowing cognitive decline, aerobic or strength training?
We don't know the answer to that question.
Yeah.
The one that you will do.
Yeah.
That's good.
That's a good one.
Oh, no. I got to keep going on that.
Oh, jeez, okay. But you're right. We need to have some definitive research where we can compare walking with resistance training and the combination. Obviously, if we could get you running, that would be fantastic, but I don't think that's going to happen. But definitely we do need some more research on how much is enough, how fast is enough, and what are the benefits of some of these other good forms of exercise.
I'd say if there was any vascular component to the disease, probably you'd lean a little bit more toward aerobic. Although, if there's a lot of muscle wasting, deconditioning, there's certainly a major element of strength training to do in addition to the aerobic exercise. So probably a little bit of both, actually.
And we're researching that here at the Pennington University. So, why is unintended weight loss a sign of frailty? And if your loved one is frail, is it best to make them increase activity?
Why is unintended weight loss a sign of frailty? It's not, in America, everybody's on a diet, right? In Europe, that's not necessarily true, and my understanding is that they took away the name Diet Coke over in Europe. They call it Coke Light because they don't like to think of themselves on diets over there. But we all love diet, so we Diet Coke. But the reality is the data have repeatedly and reliably shown that older adults that are losing weight unintentionally have an increased risk of functional loss and are more likely to die. And there are some people say that weight loss is an early sign of dementia. People become less interested in food. They sometimes, in later stages of dementia, they forget to eat or forget how to eat. So you have to remind them. But some of my colleagues believe actually it's the early loss of the ability to smell makes food less tasty and less appealing, and so older adults would eat less. But almost any end-stage heart disease, kidney disease, liver disease, any kind of end-stage medical problem can lead to decrease in appetite. And if you start seeing people losing weight, that's a big warning sign, and obviously underlying cancer can also be a sign of that. So it's a bad marker in geriatric patients, and we generally try to really pay attention to that. So that's the reason why it's been defined as a sign for frailty. Should we take frail people and have them walk? And that's a really important question. You need to do it safely. But the problem is you're going to be on a downward spiral if you have inactivity leading to decreased strength and less activity, then even less strength, then you're going to cross a threshold where the person can't get back to where they were before. And so I think it is really important to stop that downward cycle if at all possible. Now I think in geriatrics we all have to realize that all of us at least the statistics suggest that I think nearly 100% of people do die. And there does come a point where personal preference matters. And if somebody's lived to be 95 or 100 and they're tired and they don't want to exercise, I'm going to respect their choice. But, the reality is in the 70s, 80s, and 90s, the evidence suggests that exercise can still work in frail older people and improve quality of life, improve their mood, improve their brain, and make them feel better. The early studies in the 90s suggested that weight training in nursing home residents increased strength by 80%, helped people get rid of canes, allowed them to be able to walk and move around. So I think that the horse is never out of the barn in terms of exercise for older people. You just have to design programs that are safe and target them where they are at the beginning of the program.
Actually, just the one thing I'd like to add is when people talk about safety of exercise, I can definitely say that being inactive is not safe.
Yeah.
You're just full of those,
Yeah.
Catrine. I like that.
I'm full of what?
You're full of those.
You said you're full of something. I don't know. Yeah, I'd like to echo what's been said here in that, the question of whether you should walk, if you're frail, obviously you want to do it in a safe environment. So it might require assisted devices, might require a cane, walker, well-lit areas. Make sure around the house, there's no, the carpet is even, there's no surfaces that could cause falling and stuff like that. So, you make it as safe as you possibly can. But I don't really think there's an issue about if you should do it. The answer is yes, because if the alternative is if you don't, it will be this downward spiral. And then after a while, you will not have the option of walking because you will no longer be able to ambulate. So it really is, you almost have to do it, but safely and a little bit. It doesn't take a lot.
What occurs first in abnormal aging, mobility problems or cognitive problems?
Well, my hypothesis is that it's mobility, at least before we can measure the cognitive change. And that's one of the reasons why we developed this measure. We believe that if we detect early changes in mobility, it doesn't tell you why, but it tells you that something's going on. So you have to examine the patient carefully and do a comprehensive assessment of their socioeconomic status, their general health status, their emotional status, and their cognitive status. It can be a problem in any one of those domains, and if you can identify it early, you can intervene and improve the outcome, allow them to maintain mobility, and prevent the more distal adverse outcomes, such as nursing home placement, disability, and even death. At least delay it.
And that's one of the things we're finding in our study is that there's actually direct links between the way that the specific aspects with the way your brain works and gait changes that put you at increased risk for falls. And so the exciting thing about that is that it actually opens the door that improving your gait and aspects of reduced risk for falls, it may actually slow the cognitive decline that we see in people, and also it may end up being that some interventions that help with increasing processing speed and other aspects of your brain, which we know how to do, may actually decrease fall risk. So it's really interesting how this area of research is going.
Let me just make one more comment. If you ask an older person how they're doing, they'll tell you fine. And for those of you who are long-distance caregivers, you have family that are 300 or 400 miles away, and you're trying to find out how they're doing by talking on the phone. If you talk to your mom, your dad, and say, how you doing, they say fine. Well, they're comparing themselves to their peers. Well, they're going to funeral homes quite regularly. And so they say, yeah, I'm doing great. But one of the things that we've learned by doing the life space assessment, you stop asking them how they think they're doing. You ask them what they're doing. That's what life space does. Where did you go? How frequently did you go, and did you need assistance? So if you got a loved one who always went to go visit Aunt Susie every week, and she stops going to see Aunt Susie, you got to find out why. That could be early dementia, that could be depression, that could be not enough money to pay the gas or the public transportation, or it could be a new health problem. So find out what they've changed. If they always went golfing and they stopped golfing, find out why they stopped golfing. If they always went to the office, why do they stop doing that? If they always were interested in managing their stock portfolio and they stopped managing that, find out what. So ask them what they're doing and find out what they're changing. And if there's a change in what they do, then you need to explore the other things.
I think we'll do this as the last question for the evening. Can walking regularly decrease mobility issues in the aging, and is more intense exercise better?
Well, again, I'll say whatever you will do. So, stop worrying about what is the best you can do, and just do something for sure. But definitely, one of the studies that we're doing here at the Pennington is the lifestyle interventions for elderly, and we're examining how physical activity, specifically walking, and actually will help people prevent mobility issues in the future. So we're doing some research around that. But definitely what we would suggest is, keep walking in your life, keep exercise in your life. And hopefully that'll help you maintain your mobility for as long as possible.
Yeah, I'm finishing up a study looking at exercise training, both in-house, in supervised settings, and also in home-based settings for older patients with vascular disease in their legs. And these patients are very sedentary, and they're at risk for becoming non-ambulatory pretty soon unless something happens. And one of the measures that we get, and Dr. Tudor-Locke gets these measures here, so you're lucky that you have an expert right here in Baton Rouge, is to actually monitor what we call free living daily physical activity. So you put an activity monitor on a person, and then you measure how many steps they take and so forth. One measure that I think is very key is cadence. And this is simply the rate of walking. How fast can you walk? Usually when things are deteriorating, you become, as you've heard in some of the presentation here this evening, you become very slow. The speed of walking decreases. And the cadence is a good marker for ambulation, mobility, physical function. And what we found in our study is that, interestingly, when we tested people on a treadmill, after the 3 months of training, we saw these dramatic improvements in their walking ability on the treadmill, both in the supervised setting and the home-based setting. But for the free living activity, the measures that changed weren't the number of total minutes of activity. So people didn't all of a sudden now exercise an additional 30 minutes a day. But they exercised or walked about the same minutes per day, but they took more steps in those minutes. So they're accomplishing more ambulation for a given amount of time. And the very interesting thing was that did not happen in the supervised group. So the people who actually came to the center, even though they got better physiology and their blood flow improved and their walking improved, they didn't ambulate any differently in the community setting, but the home-based group did. So we're thinking that simply the home-based group learned how, and they became better at it, of walking in the community setting. And so that's one of the really neat things I think about home-based exercise, is I think there's some differences when you just go out and walk not in a setting. And I think that, I mean, there's some benefits to that. And I think we're showing it. And I think even if you walked in a center and you exercised every day, pretty soon the study ends. You know, maybe it's 6-month study. Pretty soon it ends, and you're going to have to figure it out yourself of how you're going to maintain this on your own. That's the key.
Just one thought that might be fun for some of you. You may be looking for some dating opportunities. And back in '93, there was a New England Journal article, and it was an observational study that captured what kinds of physical activity people did and whether or not which of those activities led to a reduction in dementia. And the one leisure time physical activity that was reported and observed to reduce the risk of dementia was dancing. And I do have a colleague who works with me at Emory University who is looking at a modified tango to help people with balance and gait and physical activity. And it's thought that when you're partnering, whether or not you're leading or following, you're having to adjust your mind constantly. So it's not only the body that's getting exercise, but you're also getting brain exercise and the socialization and all the rest. So I encourage you young men to get your wives and go dancing, and ladies, you guys can go with each other, and actually some of the community senior centers will have dancing courses, and there are always lots of people there, and you can have a good time while you're at it. So that might be something to try.
What an incredible matchmaker.
Yeah.
Yeah, holy moly.
I didn't know where he was going with that, so I'm so glad it was dancing.
Yeah.
Okay, so I do want to thank our sponsors. I want to thank all of our external panelists. I want to thank all of you for coming. Please go to the IDRP website to see these presentations, others. Please tell people about our studies going on here. We do have both aging as well as dementia studies, and we're going to have more and more as the years go on, and we can't do it without you. And so thank you again, and have a great night. Go Tigers.